Hi guys, so folks, today's topic is ovarian tumor, not tumors actually. Let's emphasize, clarify the important questions that confuse you. These previous year's board exams, misunderstood, confused questions. So take pens, papers, and let's go on to make the notes. So ovarian tumors are the great mimica, vast histological diversity we've got. Ovarian tumors are not a single disease. No? When you will answer in this manner. It's not a single disease. So tumors represent one of the most diverse groups of neoplasms in the human body, arising from three distinct cell lineages within the ovary. Okay? So this is a diverse group of neoplasms. So three distinct cell lineages within the ovary. Surface epithelium, leading to epithelial ovarian cancers, evidently, obvious. The most common type is one. Germ cells, like those from eggs. And sex cord stromal cells, hormone-producing connective tissue. So why it's so important? This heterogeneity is crucial because different tumor types, my beloveds, have vastly different biological behaviors, prognosis, responses to treatment, and typical age groups affected. For example, epithelial ovarian cancer usually affects postmenopausal women and is often aggressive, while germ cell tumors are more common in young women, adolescents, and are often highly curable even in advanced stages. Acute pathological diagnosis is paramount for determining the correct management strategy. For example, chemotherapy regimes, need for fertility sparing surgery, and so on. Now about vague and late presentation. Why ovarian tumors are the silent killer? The majority, around 80% of malignant epithelial ovarian cancers are diagnosed at an advanced age, so FIGO stage 3 or 4. No, FIGO is the International Federation of Gynecology and Obstetrics. So advanced stages means stage 3 and 4. So this is largely because early stage disease often produces no specific symptoms, or symptoms are vague, easily mistaken for common gastrointestinal or, my beloveds, urinary issues. Actually, it's okay for any chronic conditions, the same pattern. No clinical symptoms from the beginning. Clinical issue of that. So clinicians, future you, okay, must maintain a high index of suspicion for ovarian cancer in women presenting with persistent and inexplicable symptoms like bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, and urinary urgency or frequency, especially in postmenopausal women or those with risk factors. Delay in diagnosis dramatically worsens prognosis. A thorough pelvic examination, including bimanual and sometimes rectovaginal exam, and appropriate imaging should be considered. Okay? So next question is the CA125. So cancer antigen 125, CA125, helpful but imperfect biomarker. So it's not helpful at all. So why? While cancer CA125 is the most widely used tumor marker for epithelial ovarian cancer, it's elevated in only about 50% of early stage epithelial ovarian cancers. Furthermore, it can be elevated in numerous benign conditions. For example, endometriosis. No, actually, it's not very good example of a benign condition. But anyway, you can have this CA125 endometriosis, fibroids. What else? Pelvic inflammatory disease, menstruation, pregnancy, liver disease, and I don't talk about other type of malignancy beyond the ovarian tumors. So CA20 or 125 is not recommended. You will ask about that, the clinical importance. So this CA125 is not recommended at a standard alone screening for standard alone screening tool for ovarian cancer in the general population due to its very low sensitivity in early stages and low specificity. But it can clinically valuable, however, in evaluating pelvic mass, especially in postmenopausal women, of course, often used alongside imaging and clinical assessment, sometimes with algorithms like RMI. RMI is a risk of malignancy index or risk of ovarian malignancy algorithm, ROMA, which incorporates human epididymids, protein 4. No, I don't think you will be asked about that, but anyway, so we can use that, not we, a gynecologist, in evaluating pelvic mass, I repeat, especially in postmenopausal women. Then, why not monitoring response to treatment in known ovarian cancer patients and detecting recurrence after initial treatment. Next point about staging and cytoreduction. Actually surgery question, but anyway. So surgical staging and optimal cytoreduction is the cornerstone of management. Unlike many other cancers where biopsies often precede major surgery, the standard approach for suspicious ovarian mass often involves primary surgery that serves both for definitive diagnosis, histopathology, and comprehensive surgical staging, determining the extent of disease spread according to FIGO criteria, initial treatment, tumor removal. Okay. Clinical importance of that for advanced epithelial ovarian cancer, achieving optimal cytoreduction. So actually also called debulking, the same thing. Surgical removing all visible tumor, ideally to no residual disease, NRD acronym, no residual disease, or less than 1 centimeter of residual tumor, is one of the most significant prognosis factors for survival. So this complex surgery should ideally be performed by, of course, specialist gynecologic oncologists who have the good experience and has the expertise to perform extensive procedures like bowel resection, splenectomy, or diaphragm stripping if needed to achieve optimal debulking. And referral to a specific center is critical. That's absolutely. Now about BRCA, one of the most common questions. So BRCA connection, genetics, risk, and targeted therapy. Actually a little bit controversial here, but anyway. So approximately 1/4, 25% of epithelial ovarian cancers, particularly high-grade serous carcinoma, the most common subtype, are associated with inherited tumors, not so-called mutations. You said mutations. Actually, it's not a mutation, but anyway, with inherited mutations, most commonly in the breast cancer susceptibility genes, BRCA, BRCA1 and BRCA2. Other genes associated, my beloveds, other genes associated with Lynch syndrome, hereditary non-polyposis colorectal cancer, also increase risk. So, clinical importance of this. Risk assessment, my beloveds. Identifying women with these so-called mutations allows for enhanced monitoring, no surveillance, it's the same word, and preventable strategies such as risk-reducing salpingo-oophorectomy, RRCO, risk-reducing salpingo-oophorectomy, removal, what is this? Removal of ovaries and fallopian tubes, which significantly reduce ovarian cancer risk. So, tumors with BRCA so-called mutations or other defects in homologous recombination deficiency pathway are often sensitive to so-called poly adenosine diphosphate polymerase inhibitors. These so-called targeted therapies, very fashionable now, actually highly controversial, but you answer in this manner. So these targeted therapies have revolutionized maintenance treatment for eligible patients, improving progression-free survival. Let it be. Let it be. Genetic testing of the patient, so germline, and sometimes the tumor somatic is now standard practice for most epithelial ovarian cancer patients. Now about germ cells tumors. Ovarian germ cell tumors derived from primordial germ cells predominantly affect adolescents and young women, average age 19, while some are benign, like mature cystic teratomas or dermoid cyst, the most common ovarian neoplasms in women younger than 20. Malignant ovarian cell tumors, for example, dysgerminoma, yolk sac tumor, immature teratoma, can grow rapidly but are generally highly sensitive to chemotherapy. So why it's so important? So unlike epithelial ovarian cancer, malignant ovarian germ cell tumors have an excellent prognosis, often curable even when advanced stage disease. They frequently produce specific tumor markers useful for diagnosis and monitoring. Alpha-fetoprotein produced by yolk sac tumors and human chorionic gonadotropin produced by choriocarcinomas and some other ovarian germ cell tumors. So they frequently produce specific tumor markers, my beloveds, useful for diagnosis and monitoring. I repeat, alpha-fetoprotein produced by yolk sac tumors and HCG produced by choriocarcinomas and some other ovarian germ cell tumors. Fertility sparing surgery, preserving the uterus and contralateral ovary, is often possible, and it's standard of care for young patients desiring future fertility. God bless, huh? Now about peritoneal highway. You will be asked about that so-called transkelemic spread. Transkelemic. So epithelial ovarian cancer characteristically spreads via the transkelemic route. Cancer cells exfoliate from the primary ovarian tumor surface and travel through the peritoneal cavity via the normal flow or peritoneal fluid. They then implant on surfaces like the omentum, diaphragm, boa serosa, and pelvic peritoneum. Why it's so important? This explains why epithelial ovarian cancer often presents at an advanced stage with widespread peritoneal metastasis and malignant ascites, fluid accumulation in abdomen. It also underscores why surgical debulking involves meticulous exploration and removal of implants throughout the entire abdominal pelvic cavity, not just removal of the primary ovarian mass. Lymphatic and hematogenous spread can also occur, but are often later events. About borderline ovarian tumors, so-called mysterious middle ground. Fascinating, but borderline ovarian tumors, BOTs, borderline ovarian tumors, also known as low malignant potential tumors, represent a distinct category of epithelial ovarian neoplasms, around 15% of all. Histologically, they show cellular proliferation and atypia beyond benign tumors, but lack the definitive stromal invasion characteristics. Yes. Of invasive carcinoma. So histologically, they show cellular proliferation, atypia, beyond benign tumors, but lack the definitive stromal invasion characteristics of ovarian cancers. So clinical importance of that, my beloveds. These both borderline ovarian tumors have a much better prognosis than invasive epithelial ovarian cancer, particularly when confined to the ovary. They often occur in younger women. Management can be complex. While surgical staging is important, fertility sparing surgery is frequently a good option. Some borderline tumors, especially those with invasive implants, can recur or progress, necessitating long-term follow-up. Accurate pathological diagnosis distinguishing these borderline tumors from benign ones and malignant conditions is critical. Pathological diagnosis is critical. Now about Krukenberg tumors, or Krukenberg, no, actually, let it be Krukenberg. Tumors, the ovary is ovary is a metastatic target, so not all ovarian tumors originate in the ovary. A Krukenberg tumor specifically refers to a metastasis of the ovary, metastasis to the ovary, classically characterized by signet ring adenocarcinoma cells, most commonly originating from a primary cancer in the gastrointestinal tract, stomach, colon, appendix, pancreas, or sometimes the breast. Clinical issue. So finding bilateral solid ovarian masses, especially with signet ring cells on pathology, should prompt an urgent search for a primary malignancy elsewhere, particularly in the gastrointestinal tract, for example via upper endoscopy and colonoscopy. The prognosis for Krukenberg tumors is generally poor, reflecting the advanced stage of the underlying primary cancer. So treatment focuses on the primary malignancy and palliative care. And finally, actually it's not only for your exams, but for public health exams as well, about screening. Conundrum. Screening conundrum. Actually, it's a conundrum. So why population screening is not recommended, especially in this case. So despite the high mortality rate of ovarian cancer when diagnosed late, large randomized controlled trials have shown that current population screening methods using transvaginal ultrasound or CA-125 do not significantly reduce overall ovarian cancer mortality in average risk women. Furthermore, screening leads to a high number of false positives, resulting in absolutely unnecessary anxiety and potentially harmful surgeries for benign conditions. So why? Clinical importance of this. Currently, there is no recommended routine screening test for ovarian cancer for women at average risk. Efforts are focused, on identifying high-risk women, for example, BRCA carriers, who may benefit from enhanced surveillance or preventative surgery, and on developing better screening tools for the future. Why not? You're my guest. Be my guest. For clinicians, this means focusing on prompt evaluation of symptomatic women and appropriate risk assessment rather than population screening. Understanding these facts of ovarian, understanding all these facets on ovarian tumors helps medical students. So why not doctors appreciate the complexity of diagnosis, the importance of specialized care, the rationale behind treatment strategies, and ongoing challenges in early detection and management of this challenging group of disease, and be successful on the big board exams. So that's all. I think I clarified all these misunderstood and confused questions. Thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, and the same, subscribe my private Dr. Y channel in Telegram. Dr. Y in Telegram. So how to find? Easy peasy. Tap in searching mode in Telegram. Dr. Y, like question, why? Dr. Y, it's me. W-H-Y. W-H-Y. Without question mark, obviously. So you find this, you click start, and you choose your plan. God bless you.